So Michael and I were in Houston just 2 days ago, and we really had a lot of fun with the ACCHA guidelines. I must tell you, you should look it up. It was a blast. I think it's on the web through the Houston Aorta. Anyway, I actually think this is an incredibly important subject, and I see we have a lot of physicians, but also maybe some of the people who run our clinics, our aortic clinics, contemporary non-size risk factors, and this gets into the guidelines that just came out as well. And I'll try to, does this work? Oh yeah, you got to put it over here. Oh, okay. All right, these are my disclosures. Next, there we go. Are you doing that or? Okay. All right. Okay, so the outline is pain or symptoms, aortic insufficiency, root phenotypes, aortic length, family history, coarctation, genetics. There are some others that I just didn't have a chance to get through, which is growth rates, pregnancy, indexing, which is really kind of a diameter thing, so it's not quite so, it's in the middle, bovine arch. And then there's two that at the very end, I just want to say quickly about, which is bicuspid valve and diabetes, which actually are maybe protective against dissection and rupture risk size for size, which is an interesting concept as well. So we now have new aortic guidelines. Let's refer to these as well during this talk, okay? These should also notice that these guidelines were approved by the STS and the ATS, the surgical societies, unlike the disaster of the coronary bypass guidelines coming out of the ACC-AHA, which were routinely condemned by every surgical organization on planet Earth. So the first thing is the pain and symptoms. So these are non-diameter things to think about. So the aorta is very well innervated, actually. You can see this slide here, lots of nerves. And the guidelines show that this is in patients with aneurysms of the aortic root and aorta who have symptoms attributable to the aneurysm, surgery is indicated, period. Class 1A indication. So pain is a class 1 indication for repair. And we should never forget the symptomatic aortic aneurysms. And you know what you see usually when you open up these? This is actually from John Alfredi's. You see these little tears in the aorta. As you can see here, we see this a lot. Here's one of my patients. You can see these patients that have these kind of pseudoaneurysms and tears that end up becoming, almost like dissections. And this is sinus thinning of the root. And so pain should never be, and symptoms should never be forgotten. Okay, so what about the presence of AI? Now, this actually transcends the aortic guidelines, but also the valve guidelines, and gets into both of them. So this is from our group, and there's lots of them, a number of them like this, looking at the root of the root repair. What outcomes come from this? Looking at AI, so this was the paper, and what we found was that you look at the bottom line there. Is that even if it was repaired and done well and the patient survived and everything was great, the fact of the matter is that if you were on guideline or even a little bit off guideline, like we talked about this morning, and operating a little bit early, you still have a significant mortality risk over 10 years when patients have severe AI. So basically, Bentall survival is affected by severe AI, patient survival, I should say, so this is an important non-diameter concept. And the conclusions were worse survival is associated with severe AI and older age, suggesting earlier intervention may be appropriate for these cases. Now, the American Association for Thoracic Surgery, ATS, on bicuspid valves took a look at this and actually combined root phenotype with AI as a non-diameter indication to lower the threshold for replacement of aortas. And so you see there root phenotype or predominant aortic insufficiency cases. So this guideline places root phenotype and AI together for earlier replacement. Again, a non-diameter concept. So that brings us into our, the whole concept of the root phenotype. And most of us in our practices who have been around a bit realize that the root phenotype is definitely more dangerous than the ascending phenotype. This gets into the ACCHA guidelines that just came out regarding BAV aortopathy and the root phenotype. And you can see here, this is table 14, the infamous table 14 of the new guidelines. And what you can see here is these are actually risk factors that everybody, or that the guidelines are looking at that are non-diameter related. Family history of aortic dissection or family history of anything, aortic growth rates, aortic coarctation, which we're going to get into, and the root phenotype. So what's new is that these non-diameter conditions give basically a 2A indication for replacement at 5 centimeters in BAV aortopathy and other aortopathies, which is kind of new. So if you look at the BAV aortopathy, this is just the guideline itself, and what you see is that this gives a 2A or a 2B in basically everyone for a BAV, so it's a pretty dramatic guideline, to be honest with you. And the root phenotype is an absolute now at 5.0. So it would be considered, maybe considered malpractice not to replace a root phenotype at 5 centimeters. So what about the next one is aortic length. By the way, I just want to go back. We had a patient who was referred from another heart surgeon who had a 5 centimeter root, came in to me for a second opinion and for the possibility of a valve sparing operation. And he didn't want to wait in my office, and anybody who's been in my office realizes it's a long wait. He left the office and died and ruptured that night. So, root phenotype is bad. Aortic length. So this is a new and promising area for non-size risk factors, or non-diameter, I should say. And a lot of this work is coming out of Tübingen in Germany and some other places. So this is the neglected dimension, as this paper says. What they showed is that ascending aortic length, as you can see there, there's a hinge point at 11 and a half, and then another hinge point at 12 and 12 and a half for the probability of adverse aortic events. And so this was and this is the central illustration from this JACC publication, and you can see that the center line, they use the center line measurement between the annulus and the orifice on the greater curve of the innominate artery, and you can see I don't like showing three-dimensional pictures because they're too complicated for almost everybody, but you can see that as you get a higher length, you get a much more higher yearly risk of aortic events. And really what they did is took it a little further and added diameter plus length together. And you can see that where the blue line is, and basically put it into a height chart, so now it's an index, which is really, really worthwhile. And this is actually very impressive work, I think. This incorporates length plus diameter index to height. And you can see if you're up in the orange or red lines, which would not be so difficult, then this is something we might need to be able to consider. And frankly, we haven't been looking at this, but I think we have standard indexing in our clinic as far as our clinic notes, and we're going to start to put this into the clinic notes. Okay, family history. Family history is actually taken a huge step forward and is now front page, so to speak, in the guidelines. So you got pictures like this or papers like this, where you have 3 times the increased risk of aortic dissection in family members, and the guidelines have now gone. The European 2014 and the American 2010 guidelines were looked at first order relatives. Now they're actually talking about any any family history. So it's actually gone deeper into the family history issues. And the data is really pretty strong out there regarding family history. You have a lot higher risk. So what's happened? You can see here. These are heritable TAAAs or TAAs, any kind of thoracic aneurysm that's in the heritable conditions, and you can see they're now getting a 2A indication for family history. And what this really means is that now you can have this is new. A normal person, simple history of aortopathy, goes to surgery at 4.5 centimeters if there's 3 millimeters growth, but family member with unexplained sudden death less than 50, or a family member with a dissection. It's now a 2A indication for surgery, and that's at 4.5 centimeters if the patient has a heritable genetic cause with no identified genetic cause. This is non-syndromic. We're not talking about we're just talking about anybody with a family history. We're not talking about Marfan's and Loeys-Dietz. That's a syndromic heritable TAA, which was another which occupied about 10 minutes of our discussion at Houston. Was what the hell's we need a geneticist to even figure that out sometimes. So looking at this table 9, this is another table, and you see another table 10 in heritable thoracic aortic conditions, and also in just general conditions in Marfan's. You see that family history of aortic dissection at an aortic diameter of less than 5, family history of unexplained sudden death at age less than 50. These are the factors that take these patients down to 4.5 centimeters in many cases for these heritable thoracic aortic aneurysms. And this was this is in Marfan syndrome, which is syndromic, and also family history of aortic dissection takes you down to 4.5 centimeters. So what does this all mean? What is this? This is the recognition of the primacy of positive family history in aortopathy by the guidelines. It'll be interesting to see what the European guidelines say next year or the year after, if they agree with the ACCHA. All right, coarctation. So bottom line with coarctation is really all about hypertension and fixed hypertension. And you can see this is just one of the papers that shows that patients with coarctation or who have had a coarctation have an increased risk of death from their aortas, from their proximal aortopathy. So this gets into the whole risk factors again, non-diameter risk factors for aortic dissection, and one of them is history of aortic coarctation or the presence of aortic coarctation. So that's just another non-diameter thing to think about in your clinics. Coarctation equals operate earlier. Now genetics. So genetics is unbelievable. The amount of new knowledge since the previous guidelines of 2010 and 2014. These are the broad-based guidelines. So this is the first 2022, 23 guidelines, the first real broad-based guidelines since those publications. So it's been a decade almost, and this is beyond huge. Okay, it's an incredible explosion. So this is just one example. This is an FBN1 genetic variation. You can see even at the 50 to 54 millimeter range, you can see when you talk about it compared to 40 or 44 or 45 to 49, that with FBN1 or Marfan's variants, you get 10 times more dissection, and it's like 100 times more dissection if it's up to 55 millimeters. So these are dramatic results, and it's a good thing we've kind of figured this out. Now, this slide is kind of one of the central slides of the 300 slides from the ACCHA guideline deck. And what you see here is the kind of the array of thought processes regarding genetics and its application to aortopathy and when not to operate. Okay, and so what we have is trying to tease this out of what it really means, which was difficult, believe it or not. I looked at it a million times before I tore it apart 2 days ago with the panel. And we have sporadic, we have familial, we have syndromic, which syndromic actually really just means the big ones. And then we have this non-syndromic heritable, which I don't really understand why they did this, but they should all just be heritable. and genetic, which is it's a little bit different. So it's kind of, you have to kind of figure kind of put this into place. But the point really, the big point, 30,000 foot viewpoint, is that genetics is now very central to the entire concept. And we have, in our aorta clinic now, we have a geneticist or a genetic counselor in our aorta clinic every Tuesday. So this is something that we have acted on. This is an action item, if you want to. So all of the heritable conditions are trending towards earlier treatment in the guidelines. And if you take a look, this is kind of where they are, which is, if you look at the TGF-beta pathways, this is all the Loeys, Dietz, and the SMAD3s, and all of that whole triggering cascade of genetics. And we're down into 40 to 42 millimeters on those patients. Most of them have such strong family histories of dissection that you could actually argue for prophylactic replacement of the aorta in some patients. In the 45 millimeter to 50 millimeter range, we're talking about FBN1 and COL3. So for those of you who don't know some of this stuff, FBN1 is the Marfan's and Marfan subtypes, and COL3 is Ehlers-Danlos. I've seen a whole rash of COL5s. I don't know what COL5 is anymore. It used to be Ehlers-Danlos, but now it's some sort of weird thing that's associated with Ehlers-Danlos. So these geneticists are so far ahead of us that we can't even keep up. It's like it's like Elon Musk and the lawyers. He's always ahead of them. So and then you have the non-syndromic heritable, which I don't understand that word anyway, which is all of the smooth muscle contractions, which is ACTA2, MYH11s, et cetera, and even PRKG1, which is actually pretty serious. So I don't know why those are not, considered heritable genetic conditions, but they're not, or syndromic. So anyway, they're all, and then you see all the rest of them over there on the right, which will probably end up shifting over to the left as we learn more about them. So the concept is genetics is huge. It's going to be playing a major role in what we do. All these genetics are going to coalesce over to a shift to the left, and they're very, very important in our clinics. So thank you very much. Questions now or later. Well, two last things. As I said, as it's turning out, bicuspid aortic valve aortopathy, size for size, this is the opposite issue. So we always talk about shifting to the left. Well, this is a shift to the right, maybe. Bicuspid aortic valve, size for size, is less virulent than tricuspid valve, size for size. So a 47, 48 millimeter aorta in a three-cusp valve is worse than a 47 or 48 millimeter aorta in a bicuspid valve. That's becoming more and more apparent. And the second thing is that, when was the last time you guys saw a rupture in a diabetic? Diabetes is probably protective of rupture. Anyway, shift to the right on those twos. Okay, sorry. Questions? Or is it time to go?
No, don't go.
It's Walid Al-Mahdi, surgeon from Leeds. Thanks for the great presentation. Just a question regarding not the family history, the personal or individual history of dissection. So a patient have a type B dissection, because it's not addressed in any guidelines. What are the size that you can follow?
Yeah, I would think that that's a great question. I don't think it's in the guidelines. But if your first order relative has had a dissection, then your zero order relative, which is you or your twin, identical twin, has had a dissection, then you probably should follow the first order relative guidelines. It's probably the way I would look at it. Yeah.
Dr. Bavaria, what's your view on the biomechanical risk factors emerging, such as wall shear stress and aortic stiffness? What role are these going to play in the future?
Yeah, I think they're going to play a big role, and that has actually been looked at. There is some minor stuff about that in the guidelines, especially in the imaging section of the guidelines, where the new imaging processes can do wall stress analysis and stress analysis on the wall. And so I believe that that's a big deal. And for example, you can even tell just looking at type B dissection that's chronic, if you do your CT scanning and do a stress analysis on the aortic wall in zone 3, at the level of the primary tear site, which is why some of the reasons why we're doing TVAR in type B dissections with high risk features. I mean, the wall stresses are off the charts across in zone 3 across from the primary tear site. So that's why you do these things, these TVARs prophylactically, because you know they're just going to blow because they're just and grow because the stresses are 5 times higher than they are in the true lumen. So yeah, I think that's a big deal. It's not quite ready for prime time regarding the guidelines. You know, it's like what I said about the fact that and I'd love to see what happens with the European guidelines, but if you come in with a root aneurysm and you're Marfan's or whatever, it doesn't matter what kind of aortopathy you have, and you have a normal valve and you have a root aneurysm, they only give a 1A to a valve sparing operation. And my thought process is, if it's malpractice not to do something, it should be a 1.
Just one question, if I may, before you go. The guidelines now, they have established the MATs, the multidisciplinary aortic teams. Yeah. And we are trying to give it a framework here in the UK as well. I just want to ask you, how many aortic nurses do you have in your clinic every Tuesday? Oh. And also, how do you go about saying, I need the geneticist present, full stop?
Yeah, that's a good question. Well, you know, I'm in America, you know, so there's more money in America, but we have a lot. You know, we have resources, and I have gone the biggest way. I mean, this is like, if it's not about the money, it's about the money. You know, so when you go to our administration and tell them how, you know, how powerful the aortic service is, and then they'll listen if you have the numbers. So we've gotten a lot of nurse practitioners in our clinic, a ton of nurse practitioners. We also have a co-clinic with the vascular. So our clinic is right next to the vascular surgical clinic. So we're together. We have a lot of nurse practitioners, and we have recently got or received funding just a couple of years ago for a geneticist / genetic counselor. And you can take these guidelines, this is kind of a quality safety MDT kind of thing, to your administrator, say, hey, listen, this is what's recommended now by the worldwide authorities, and maybe use that to help you get your resources. My experience, administrators only think about one thing, though. It's either money or not money. It's a tough group to work with sometimes.
Can I just ask a quick practical question? Yeah. Because I'm sure you have thousands of patients in your clinic under follow-up.
Yeah, 2,500. That's why I need nurse practitioners. Yeah.
Well, it's just, you know, the guidelines have changed overnight. And so are you systematically going through that cohort of patients and bringing them all back early, or do you just wait for them to appear in a year's time? That's
a great question. Same thing happened in 2010 and 2014 when the guidelines changed, for those of us who have enough gray hair to remember those days. But we just, you know what? We just let them, we don't scare them. We let them come back at their normal visits and talk to them then. Good question.
Gives me great pleasure to introduce the next speaker, Dr. Martin Czerny, who's the Heisenberg Professor of Aortic Surgery at the University of Freiburg. He'll be talking about contemporary classification of acute aortic dissection.
Yeah, dear chairs, dear colleagues, it's my pleasure to share with you a few conceptual thoughts how one should eventually talk about acute aortic dissection nowadays. These are my disclosures. Let's start with a bit of pathophysiology. I think one of the most important things one should realize when talking about acute aortic dissection is the propagation of the dissection from the level of the primary entry tear. And the most important component of this is that when the initial injury to the aortic wall has happened, propagation not only goes downstream along the bloodstream, but always has a retrograde component. And this retrograde component at the end determines the clinical severeness and also how we talk about the disease. And so the location of the primary entry tear is of paramount importance because, as shown in this slide, if the primary entry tear is located at the outer curvature, the retrograde component is highly likely to stop at the level of the supraortic branches, which will act as an anatomical barrier preventing further retrograde progression into the arch and into the ascending. This is the reason why type B with the primary entry tear at the outer curvature remains a type B. And if the primary entry tear is located at the inner curvature, an initial type B may become a retrograde type A, usually in combination with malperfusion, because the ones who do not have the primary entry tear in the ascending are the ones who are very likely to be associated with visceral and renal malperfusion. And this is a pattern which can be seen over each and every acute aortic dissection and over each and every intramural hematoma, because the majorities of intramural hematoma, eventually all of them, do have a primary entry tear. You just have to look for it, and usually it's located somewhere in the distal aortic arch. So the fundamental principle is the harmonization, the conceptual fundamental principle is the harmonization and the understanding of the location of the primary entry tear together with the extent, in particular with regard to the retrograde extent. And now let's have a look at this simple graph, which just is a simple correlation of outcome in association or absence with malperfusion. So in acute type A, let's call it uncomplicated type A, will have a 30-day mortality of about 10 to 12%, dependent on the frame conditions. And each and every organ involved in the malperfusion process will double risk of mortality, and this is completely independent of the conceptual approach of surgery, which will remain ascending and hemiarch replacement in the majority of patients. And this is the multivariate analysis for here, the regression for the persistence of malperfusion. And this is actually from a time where the persistence and the pathophysiology has not been adequately understood, or where the devices have not been available. As you can see, a location of the primary entry tear in the descending aorta is an independent risk factor for persistent malperfusion, because ascending and hemiarch replacement will not be able to fix the entire thing, and frozen elephant trunk implantation is needed. So how can we harmonize this knowledge on pathophysiology into a very simple algorithm everybody can use and everybody can apply already at the level of the emergency room before the treatment, to develop the treatment concept? And one of these ideas is the TEM classification. So where is the idea from? The idea actually is from oncology, because if you think which classifications are out and vivid for decades, well, TNM obviously is one of them, and eventually the most prominent one. So the idea was to take the matrix of the TNM system from oncology and see what can be done with that in acute aortic dissection. And this is what it is. T is for type. This is type A, involving the ascending, type B, involving the descending, or the subtype non-A, non-B, involving the arch, either with the location of the primary entry tear within the aortic arch, or by a retrograde IMH component, which is frequently the case in pathology starting as type B aortic dissections. Then, eventually, the most important component, location of the primary entry tear. If you develop a new classification, always stop by 3. Everything beyond 3 is too complex. It has to be between 0 and 3. Then it works. So E0, no entry tear detectable. It doesn't mean it's not there. It just means it's not detectable at the time being. Type 1, any proximal location of the primary entry tear from the root level to the offspring of the brachiocephalic trunk. Then E2, any primary entry tear at the arch level. And E3, any downstream location of the primary entry tear. And then malperfusion, metastasis of acute aortic dissection, which is actually what malperfusion is. M0, the nice one, no malperfusion present. M1, any proximal malperfusion, which means coronary malperfusion, and actually also cardiac tamponade, which is the same pathophysiological mechanism. M2, any malperfusion associated with affection of the supraortic branches, and M3, any downstream malperfusion, which is spinal, visceral, renal, and extremity malperfusion. And there is a difference between radiological malperfusion and clinical malperfusion. And this is the reason why a small plus should be added in case that radiological malperfusion is also associated with clinical symptoms. And this is the simple card you can download from the initial description having been published in the Interactive Cardiovascular and Thoracic Journal in 2021 with Hans Sievers as the first author, so to say. This is a second Sievers classification if you want to. So, next one. Actually, what do we have in anticipating mortality risk in acute type A aortic dissection? Well, it's STS score and it's Euroscore, but both have not been made for that because patients included are not primarily aortic patients. Eventually, you are aware of the Gerada score. Just for curiosity reasons, who uses the Gerada score in clinical practice? Hands up. Very good. One, perfect, I'm happy. And eventually, if after these talks several else will use it, you would make me even more happy. So what is it? Gerada is a German database of acute type A aortic dissection, which recruited patients between 2005 and 2011. So the recruiting phase is closed now, and we're focusing on the follow-up, but we have 2,600 data sets of patients with acute type A aortic dissection. And so the idea was to develop a web-based application to calculate 30-day mortality risk out of this database. So all patients who had acute aortic dissection and who underwent surgery. And this is the simple matrix. So this simple matrix has clinical components and has radiographic components, and it takes you 60 seconds to calculate the score. And the score is available on the webpage of the German Society for Thoracic and Cardiovascular Surgery without any cost, and is ready to use like the Euroscore or the STS score. And now let's do a combination of the TEM classification and the Gerada score. So let's take a nice dissection. Type A, E1, so a primary entry tear somewhere in the proximal thoracic aorta between the root level and the BC trunk offspring, and no malperfusion. So this patient has a calculated risk of 8.9% for 30-day mortality. This is the nice one. And the operation is ascending and hemiarch replacement, because what we want to do, we want to exclude the primary entry tear from circulation or resect it. So ascending and hemiarch replacement is the way to go. Next clinical example. Type A, primary entry tear, still located in the ascending aorta, but we have a malperfusion of the supraortic branches, so a hemiplegic patient presenting to us. The surgical concept is still the same, ascending and hemiarch replacement, but mortality doubles because of symptomatic malperfusion of the supraortic branches. So let's take the entire thing to the next level. Type A, still the primary entry tear located in the ascending aorta, but we have severe visceral and renal malperfusion. The surgical concept is still the same, ascending and hemiarch replacement, but mortality doubles, now 34%. Now, summarizing this, we have the first time the opportunity to combine a morphological evaluation, which is the TEM classification, with a risk score, which is the Gerada score. In other words, we do have a Euroscore for acute aortic dissection, which is the TEM system, and we have a syntax score, which is the Gerada score. So we have a way new option to talk to patients, to talk to relatives, and to talk to referring physicians, because we can quantify what is going to be expected, despite the operation always stays the same in case of an E1 situations. But the way you're able to talk to others has now dramatically improved. So let's come back to the treatment strategy. So we said the location of the primary entry tier at the end determines what is to be done. And as about 15% of acute aortic dissections will have acute type A aortic dissections, will have their primary entry tier at the distal arch or the proximal descending aorta, we need surgical strategies to exclude these primary entry tiers from circulation, because many of them will not be reachable in a classical surgical fashion. And so the frozen elephant trunk technique has to be part of the armamentarium of an aortic clinic treating patients with acute type A aortic dissection. Here, a clinical example of a 50-something-year-old patient with acute type A, where the primary entry tier was located distal to the left subclavian artery. This is the intraoperative view, and here the aortoscopy of the primary entry tier distal to the left subclavian. So a longitudinal tier, a very smooth intimal surface, because they never have atherosclerosis. And so, as in nearly all of these patients, the short version of the frozen elephant trunk is sufficient to exclude this primary entry tier from circulation. So in acute conditions, the 10 centimeter component is enough in the overwhelming majority of patients, and I can just recommend to stick to the concept, because the remaining risk of symptomatic spinal cord injury, if you go down to 25 or 26 degree core temperature and always use the short version, is very, very low. So concluding, it's all about the location of the primary entry tier and the extent of the disease, and the retrograde propagation dependent onto the location of the primary entry tier and the involvement of the supraortic branches, which can act as an anatomical barrier, make the difference. Distal malperfusion in acute type A aortic dissection, be it spinal, visceral, renal, or extremity malperfusion, is very often associated with the primary entry tier distal in the distal aortic arch and the proximal descending aorta. And with the TEM classification and the Gerada score, we have a new platform of talking to patients, to relatives, to referring physicians, to discuss in the emergency room and to anticipate outcome. And fingerprinting of aortic disease improves understanding and determines the treatment strategy. Thank you.
Any questions?
Yes. Thank you for the presentation, fantastic. Talking about the Gerada score, so if you have a patient with a Gerada score of, let's say, above 60%, so you are entitled from a medical point of view to go ahead, or irrespective of the number, you offer surgery all the time?
That's an extremely important question, and the score is not meant to prevent or to put people off from receiving treatment. It's just meant as a risk estimate. So the level of the Gerada score will never ever put us off from treating somebody. It will be the clinical condition eventually, but never the level of the score. This is just an estimate. Mm-hmm.
Thanks for the great presentation. Just a question, if you have a patient presenting with malperfusion already and symptomatic M+, would you treat endovascular ischemia first and then do a limited tear-oriented surgery, or go for frozen elephant trunk?
Extremely important question. Without doubt, this should be considered. It does not mean that it should be done. I think it depends on, let's say, the 4 dimensions of the evolving situation. in case there is no high-grade aortic regurg, in case there is no pericardial effusion, and if you have a double-digit serum lactate, this is a very smart way to go, to wait for metabolic recovery, to monitor the development of AR or a pericardial effusion, and then go to surgery after metabolic recovery. We do it rarely, but we do it extremely rarely, but it's a very viable option, and I'm pretty convinced that the next guidelines will mention that this is an option in these devastating clinical conditions.
Yeah, they do mention it. They do mention it. However, immediate surgery is class 1, and TEVAR surgery for mesenteric malperfusion is not class 1, it's class 2. So still, immediate surgery is the recommended way to go. But I think under his, double-digit lactates, blah, 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 it's probably,
I think there was a question at the back.
Yeah.
Hi, thanks for the talk. Quick question. You focused a lot on the entry tear, but the primary entry tear, but obviously you have many cases where you have secondary re-entry tears down in the descending. How do you account for this in your risk model?
It's an excellent question. So actually the risk model does not account for that, and also clinically sometimes it's extremely difficult. So it's an approximation, because we always have discussions if we have, let's say, two larger communications between lumina at different levels. It remains a matter of the let's say, of clinical experience and of determination what is now called the primary entry tear and which is a communication between lumina. This is sometimes absolutely not easy. But the clinical condition leads you to a more strict triage, which is which. Because the ones causing, and the point is like in acute type A, if you have visceral and renal malperfusion, then a large communication between the lumina and the distal arch and the proximal descending is responsible for this malperfusion, and therefore is called primary entry tear. But it's an ongoing discussion.
Shaquille.
Thank you. Excellent presentation. So basically, just a comment that if it's a static obstruction of the causing malperfusion of the mesenteric ischemia, you would go for TEVAR option first, won't you? Because those patients' outcome is very bad. Second question really is in type 1 without an entry tear in the arch or descending, would you ever consider AMDS at all? Because it does expand the lumen quite a lot, and the early postoperative pictures are beautiful. We don't know the long-term results, obviously.
Let me start with the second question. So I think the ones where you have a beautiful result after AMDS, you would have a beautiful result without AMDS too. Yeah. Without any question. Yeah. So simply these patients don't need it. Yeah, and the thing is, if they fail, and the first failures are out, it's extremely complex to fix that. Actually, you have to start from scratch. You have to do a frozen, you have to reline, and then you have to do the remaining open. So I think it's all about the concept has to be surgical resection or closure of the primary entry tear by a stent graft. That's the concept. Everything else is too simple.
Yeah. Thank you. You still don't believe in AMDS.
No. Yeah, there was a question at the last row.
Just as regard the M in TM classification, is it upgrading? So if we say M3, this means the patient had M2, or if sometimes patient had supracoronary and got, so we'll say M1 and 2.
Excellent question. So if there is malperfusion at several levels, we mention it. So it's not that, let's say, if there is a combination of coronary malperfusion and visceral, that M3 beats M1, it's then M1 and M3.
Thank you.
Last question from Professor Wu.
I think in bottom of re-entry tears, I know that your kind of classifications are excluded, because that site of re-entry tear determined that the extensiveness of procedure that we need to perform, it comes with the risk of mortality too. So I think we can't actually, maybe one of the guidelines should be that inspection of the aorta, like an angioscope, so that we know that there's re-entry tear in the proximal DTA. If you leave it just to interposition graft, quite a lot of patients end up having a kind of early and a catastrophic effect, even in the intraoperatively. So I think we shouldn't be ignoring that the re-entry tear
especially in the proximal part in arch, proximal half of the descending at least.
I'm fully with you, but I think this particular, because also we had the discussion if a kind of arch inspection should be a recommendation. But actually, this is needed in case you go to the OR with just an echo, and hopefully few people do. Because if you have a CT scan with a sufficient depiction of the scenario, then you know what is to be expected, and that it changes between the time of diagnosis and the time of hypothermic arrest and arch inspection is unlikely.
Great. Thank you very much for that very insightful talk. So I'd like to welcome Michael Sabbatai. He was very anxious. He felt that his whole talk was being answered in the questions in the last session. But he's going to talk to us on malperfusion in type A aortic dissection and how to manage this in a contemporary way.
Thank you very much, Betsy. And I'm glad that this session is all about concepts. I think the era of, just a simple tube graft and we have sorted out the acute type A dissection is bygone. It's quite good to see. Can I have my slides up, please? I think they're loading, and I will. What I will aim to do is also stress the concepts. Can't see anything there. What was your sabotage? So I'm going to be stressing the concepts, give also some definitions for the non-surgical colleagues in this room, and how we can incorporate that in our practice, starting from our clinics and carrying on with our surveillance clinics as well. So this has already been outlined. This is, I'm just echoing Joe, that the type A acute aortic dissection is a total aortic catastrophe. It's not just the aortic catastrophe, it's an arterial catastrophe. And I keep saying to our training sessions that, be it in theaters or outside, by the way, that a type A dissection is all about malperfusion. So a malperfusion is a catastrophe of the catastrophe. It really is. And I'll explain to you why. Although my colleague Aristotle, I graduated from Aristotle University of Thessaloniki, by the way. So he describes, he's the first one who has described the aorta, although Hippocrates about hundreds years earlier, in his attempt to describe the trachea, he named it the rough artery. So trachea means rough. You can see Greek civilization actually is quite unique because it has depicted a lot of details from social life to war on vases. And you can see that one in the middle. And the aorta is really a hanger where they used to hang their daggers in order to fight. Out of this hanger, the aorta hangs the heart and all the other organs. I think Aristotle was mainly focused on the heart, but I'm going to be focusing on the other organs as well. So there you are. I think we have gone through this already. When a type A dissection comes, please take the aorta all the way around and consider all the arterial beds. Going back to the definition, the malperfusion is a diminished blood flow to the arterial to an arterial bed of any of the vital organs, but the malperfusion syndrome, as we call it, is the diminished flow that has an impact to the function of this organ. Our American colleagues have already done the definition in 2021, and you can see this on the left-hand side. And on the right-hand side, you can see the types of malperfusion as defined recently by the American Heart Association document. So you have a static one, which means that you have the false lumen compressing the true lumen, and then the branch gets compressed. And you can get anything from renovascular hypertension equivalent to mesenteric ischemia. The most common one, I think, it's also the dynamic. You can see it in the middle, that it falls, the diaphragm falls into the true lumen, obstructing the flow. And sometimes it can go the opposite way. We always tend to think that the obstruction happens during systole, but diastole also can cause on the other side of the tube of the aorta also an obstruction. And the bottom part is a combination of both, which can be quite lethal. What is the incidence of malperfusion? We've heard from Dr. Bavaria and Professor Jenny beforehand. It ranges between 15 to 40% in patients with type A acute aortic dissection. And I was trying to dissect a little bit more the literature. When it comes to coronary malperfusion, it affects 6 to 11% of the cases, with the mortality being really high. And the mortality, obviously, if it's for the left coronary artery, is much more significant than on the right. Cerebral malperfusion affected about 11% of the patients in the German registry, and we have heard from Professor Jenny just before, and 4.7 to 14% in the rest of the literature. When it comes to mesenteric malperfusion, it's not very common, but it's very lethal. It affects about 60% of the type A acute aortic dissection patients in the German registry, 4% in the International Registry for Acute Aortic Dissection, and in other publications, 1.4 to 9.5%. Renal malperfusion widely ranges between 2.8 and 9%, and lower limb malperfusion 15 to 40%, and I'll hope Tommaso will agree with me when he talks about lower limb malperfusion as well. Spinal cord malperfusion 2 to 5%, and multiple organ malperfusion 5 to 9%. So that's the incidence. That's what you should expect when you're on call for your type A dissections. What is the mortality of malperfusion? It definitely increases a lot, 30.5% versus 6.2% presence or versus absence. In some of the series, it can go up to 43%, the presence of malperfusion. And we do know that preoperative malperfusion adversely affects short and long-term survival. So that's, I think, it's another question worth looking into, and there isn't a lot in the literature at this time. There is a variability of the impact of malperfusion based on the state of the organ and the state of the patient. We've heard, and I'm not going to repeat it, from Professor Jenny about the impact of malperfusion in the German registry. And the more arterial beds you have affected, the higher the malperfusion is. You have also seen this table. The coronary and maybe the mesenteric malperfusion are probably the most lethal ones. I think the presentation would have been complete without guidelines and without reference to the PEN experience. It goes beyond the three options, which is for, as mentioned before, it has the extra one, and it really ranges from somebody who's hemodynamically very stable without any signs of malperfusion to somebody who is really in shock with multiple malperfusions, beds affected. The more you have, the worse it is. And a lot of the discussions and also our management is going to start revolving around the concept of malperfusion. I have added also the Nordic acute aortic dissection registry, which pretty much repeats the same theme. So the management of malperfusion, the aim is to have an emergency reperfusion of all malperfused arterial beds while avoiding the risk of rupture. And I'm saying while avoiding the risk of rupture is because certain choices that we may have, they will lead unavoidably into delay of sorting out the proximal ascending and hemiarch. So the options that we have is pretty much the central repair that we've been talking, which involves the replacement of the ascending aorta and the proximal arch as basic. Various endovascular techniques for fenestration and stenting, and the extra anatomic bypasses. And the principles around this is that the immediate central repair mitigates the aortic rupture, prevents the mortality, prevents as much as it can the mortality from cardiac tamponade, coronary ischemia, and aortic regurgitation, and rediverts the flow to the true lumen. It does not address the fixed malperfusion, and I think we discussed that a little bit earlier on. Addressing the malperfusion by organ perfusion first, it mitigates the lethal systemic inflammatory response that you will get from prolonged ischemia, and you're going to have to deal with that during your reperfusion rewarming time, but you now have added on a longish cardiopulmonary bypass and some transfusion reaction from the necessary requirements that you will face. It does not address the risk of rupture or a progressive organ failure when multiple organs are involved. The statement has already been mentioned. The representation of cardiac surgeons and vascular surgeons was quite prominent. And putting it all together, the imaging evidence of malperfusion is present at 25%, and there's a difference between the imaging the malperfusion on imaging and the clinical one, and these two should be combined. But it should be distinguished from the clinical evidence of end organ ischemia, as we said. It gives also the definitions about its vascular bed, which helps communication and uniformity in our terminology. The message, first of all, it should be that a very clear-cut type 1 indication is that in an acute type A aortic dissection, replacement of the ascending aorta and hemiarch, it's your first line of approach. I put that slide on also as well for the third point, which is in patients presenting with a non-hemorrhagic stroke, complicating your dissection. The surgical intervention is reasonable over medical therapy. A lot of discussions have been on a day-to-day basis about a stroke putting you off doing a type A dissection, but when it comes to stroke, that should not be the case. The second is malperfusion. In the statement, the malperfusion issue makes an entry. And it's very clear that in patients with type A aortic dissection presenting with renal, mesenteric, or lower limb malperfusion, which are the most lethal ones, it is recommended to proceed with central repair. Now, the little bit of a confusion that I had reading this is that the type 1 recommendation is also type 2A. And it is being put into in the context of mesenteric and lower limb malperfusion, because in these cases, especially if you have lactic acidosis, you probably may have to consider addressing the malperfusion first. When it comes to coronaries, I think the malperfusion probably needs to be dealt with a central repair irrespectively, and have the PCI option in the back of your mind if you have it post-operatively. And the mesenteric and the lower limb ischemia, every now and then with a combination of lactic acidosis, it should be, you should think about calling your vascular and endovascular colleagues for an opinion. I think we discussed about the guidelines. You like them, you hire them. You don't like them, you fire them. The 2021 Society for Thoracic Surgery in the States recommendations are more clear in terms of how do you deal with the most lethal parts of malperfusion, which is mesenteric lower limb. And it's a clear 2A recommendation with no confusion. The algorithm is also very clear. But the emphasis is a little bit on the malperfusion of the gut and the lower limbs, which sits not towards the left, but it shifts towards the right a bit. And this is the malperfusion that you should really consider either an extra anatomic bypass or an endovascular intervention prior to your surgery. The presence of lactic acidosis, I think, is what makes the difference, and it should probably be made clear in the next guidelines. So in order to put it all together, each arterial bed presents different challenges in our management. There is a variety of strategies. There are variable degrees of evidence to support their use. Be careful and also keep in mind of clinical versus imaging definition of malperfusion, and also keep in mind that ischemia brings reperfusion and reperfusion injury to the entire body and to that particular arterial beds. Malperfusion is lethal. Presence of stroke should not put you off from operating. Ongoing coronary malperfusion is lethal. Operate first, but PCI can be invaluable postoperatively. If you think that coronary malperfusion when you start your case is an issue, retrograde cardioplegia, and don't give antegrade until you inspect the roots and see if you can directly cannulate the coronary osteo for antegrade cardioplegia. Mesenteric and lower limb malperfusion with lactic acidosis probably has the worst prognosis. The more vital organs are involved, the higher the early and the late mortality. Keep in mind that 65 to 70% malperfusion resolution is fixed, is fixing the primary tear. I think Professor Jenny has gone through this already. I think the concept should always be there the moment we receive the referral of that acute type A dissection and onwards. And it all hinges to understanding the role of malperfusion and where it fits in the management of acute aortic dissection, and possibly identify the cases of malperfusion that they will have worse outcome than rupture and address the malperfusion first. So think beyond the rupture, think beyond the tube graft, think aorta, think malperfusion. I'm just going to finish with this case because I was trying to think which is the worst one that I have had, and this one is a case that involves multiple type A acute aortic dissection back in 2019. 59 years old, presented, he came through my vascular surgery colleagues because he presented with lower limb ischemia. You can see here, it's a nasty one. It involved the aortic valve, although no aortic regurgitation, but I'll show you where we had our coronary malperfusion. And as it goes, you will see that the distal descending thoracic aorta is completely occluded, and the left kidney is showing up of signs of imaging malperfusion already. I can show you the sagittal view as well. Have a look at the descending thoracic aorta. So in essence, this patient had a dynamic coronary malperfusion, a bit encephalopathic, and lower limb ischemia to his right side, because this is how he presented with intense pain. I will show you the echocardiogram. This is like the double aortic valve sign, and it was not a coronary dissection, but it was the flap that was causing the intermittent coronary malperfusion. This the view of the proximal descending thoracic aorta, probably a re-entry at some point there. This is again imaging malperfusion, dynamic and fixed. And what happened with this case, we rushed from accident emergency to theaters. Lines went in, we're getting ready to start. Lactic acidosis was at that time about 10. And I remember I was sitting in the conference room getting ready, waiting for the anesthetist to call. And the nurses called me in because while they were transferring from onto the operating table, they noticed that the patient was really very heavy. So I went in, and then when we tried to prep him, we just couldn't lift his left lower limb. It was just rigid, the whole lower limb. So then I called my vascular surgical colleagues. They had a look. There wasn't anything to do in terms of a crossover, and the vascular options were not there. By that time, the lactic acidosis was 15. I decided to call it a day. So I'm not too sure how high it's going to score into the German registry, but these cases, they will become more and more common, I think, and where malperfusion comes is how you operate, what you're going to do. You need to know your therapeutic options, and you need to know when to say no. Thank you very much.
Any questions for Michael? You have one.
Mike, I have a question actually. And I just wanted to stimulate opinion about this. So from our vascular, endovascular, and the lower limb malperfusion, there are more than one way, including the XFEM, etc., temporarily. But for the SMA malperfusion, the option would be endovascular, stent, TVAR, etc. So generally speaking, we, as we mentioned, we're very OCD about a good proximal sealing zone. This doesn't exist in these patients with a type A. So while we potentially could put a stent, but then there's a very likely deterioration of your retrograde or rupture. So when the guideline left it difficult because it suggested 1A, yes, stent is fine, but then when do you do the operation? When the lactate comes down, the lactate may not get down, we might trigger a proper rupture. So how do we time the process in terms of the endovascular intervention in this specific scenario and the next surgery?
Yeah, I think I'll let Professor Jenny also comment on this. What is known in the principle in the literature, and I think, if I'm not mistaken, and Joe can correct me, the whole discussion about this started from the reports from Michigan, from the Michigan group, maybe other groups earlier on, but they will deal with that, and then they will wait until the patient becomes more stable in terms of some of the signs of clearing the lactic acidosis, and then operate. And of course, when you take that group and you compare it with the acute situation, mesenteric ischemia, now you have an urgent or a semi-elective case which has self-selected itself as a survivor, and you take the advantage. This does not necessarily justify going always for an endovascular option, but it introduces the concept, and right concepts, if they evolve, they're here to stay. Professor Jenny.
So the Gerada score is 69.2%. I just calculated that.
Thank you.
And I think this is a perfect example.
The lactate level.
Well, it isn't, yeah, but it should actually. Yeah. But I think this patient selected himself as a non-survivor because of the stiff leg. Yeah, you can't do anything against that. I would say all with regard to visceral and renal, this is not the issue. But the limiting factor is this one, yeah? And eventually the only thing, when we do have these kind of cases where functional occlusion of the infrarenal segment, yeah? So I would say it's double arterial cannulation, which might help in these situations to have at least one femoral. But if you have a stiff leg already, the entire thing is done.
Yeah. I think, if I remember correctly, my vascular colleague at that time, he said that there is no endovascular option, and if I disarticulate his leg, it's going to be a higher mortality than your operation, which was already too high. Professor Bavaria.
So we looked at, this idea of as you could say, the American College guidelines were a little schizophrenic, because they gave a 1A on one side, and then they just went back and said the same thing and it's a 2A. So it was really, not very well thought out. But we actually decided to look at this. It's not published yet. We just presented it at the STS. But we looked at our patients, and we looked at immediate repair versus not. And the immediate repair group compared to the Michigan and to the Emory groups, which were delayed, we had about a 10% improvement in mortality from 45% mortality in there to about low 30s. So my point is, it's not any worse to do immediate operations. And when we do immediate operations, and you can comment on this, with these malperfusions, we're going to always direct aortic cannulation of the true lumen. Fast, furious, direct. As soon as you put them on bypass, they start making urine, and we don't mess around with any femoral or any axillary or anything, and get the true lumen perfused right away. So I think the data will be coming out that, you know, if you look at the data from Emory regarding stenting, it's the mortality rate is really high. And I think what ends up happening more often than not, and it just happened to me too, the same thing just happened to you just last week, is that you have to make a decision not to stent. You have to just make a decision to either operate or say no.
Yeah, absolutely. And, I think that regarding the central cannulation is the concept to me for your cannulation options of antegrades perfusion of the whole body, if it's axillary or not. The central cannulation is quick, easy, and really diminishes the time of onset of symptoms to bypass.
Thank you very much. We've got next speaker to present.
So, give us a great pleasure to present my colleague Tommaso Donati, who was our colleague in London for a while, and now he works at the Gemelli Hospital in Italy, Rome, Vatican City. Thanks, Tommaso.
So thank you very much for the kind invitation. It's really an honor and a privilege to be in front of such a distinguished audience of cardiac surgeons. So I feel humbled. Michael, although I completely agree with your statement regarding lower limb malperfusion, I hope you will forgive me if, in the interest of time, I've chosen to focus my presentation on visceral malperfusion and type B dissection, which I think is somehow the more challenging and less easily recognizable form of malperfusion. So when we talk about malperfusion and visceral malperfusion and type B dissection, we are still facing a significant challenge. And the first thing to understand is that even within the wider range of patients that we define as complicated type B dissections, patients that present with visceral malperfusion and malperfusion in general represent a unique cohort of patients. Those patients, well, malperfusion, as you can see, presents approximately in 20% of the patients. And when you have malperfusion and an acute type B, then you will see also higher mortality, a higher need of adjunct procedures, reintervention, and higher level of complication in these patients. Although once you have identified the right patients to treat and you have treated them successfully, then the long-term outcomes are pretty similar to uncomplicated type B dissections. In the past, several series have failed to show that there is an actual clinical advantage when you aggressively treat those patients for malperfusion. However, there are also more recent data that shows that when you add to a TIVR procedure in a complicated type B dissection also visceral stenting or peripheral procedures, you are actually not adding complication to those patients, and therefore this is somehow suggesting that you might adopt a more aggressive approach to these patients. However, those data, I think, hints at the fact that optimizing, standardizing treatment for these patients is not more about how you are going to treat them, but when you are going to treat them and which patient you are going to treat. And this is a pretty difficult equation that involves clear definitions of what we call a type B dissection and malperfusion, understanding the underlying mechanism of the malperfusion, our ability and inability of making precise diagnosis of malperfusion, and then only at the end choose the right intervention for our patients. So Professor Czerny has shown us very well how important are classifications and how important is terminology. And we're now dealing with several classifications that we are invited to use when publishing papers or when reporting standards, and we're also dealing with recommendations or when treating those patients. And how we call things actually have a consequence in what we are going to do. Imagine that you are in MDM, you have a patient with normal renal function, you have radiological features of malperfusion of a kidney. And then you also find out that the dissection is involving the mid-arch. And then in the same institution or in the same hospital or in two different cities, if in the MDM you call this dissection, according to the SCTS classification, a type B19 classification, then you might feel justified by the guidelines to call this a complicated type B dissection and end up doing this to the patient. Is this appropriate? We don't know. It depends. You might get away with this operation, but it's a very complicated operation. While if in the same MDM you're going to call this a non-A, non-B, E1, M3 classification according to the TEM classification, then you might be pushed to think a little bit outside the frame of guidelines, and you might be actually tempted to say, the branching is too complex, let's treat him conservatively, and you might get away with the same result for the patient or even better. So, and also definition about malperfusion is very confusing when you read the literature. Papers report as visceral malperfusion, mesenteric malperfusion alone, renal malperfusion, a mix of both. And also, when we see patients treated for malperfusion, in very few papers you will see a definition of malperfusion, a distinction, between malperfusion and actually end organ ischemia. So is radiological malperfusion organ ischemia? Yes and no, we don't know. We've seen in the presentation by Michael the mechanism of obstructions that I'm sure you're all very familiar with. So we have dynamic and we have static mechanisms of malperfusion. Dynamic obstructions basically is a conflict between true and false lumen. You usually do not have a direct involvement of the ostium or the vessel, and dynamic can be, but doesn't mean intermittent. Static obstruction, at the opposite, involves always the ostium and the target vessel that you are considering for a potential malperfusion, and you can have very different outcomes when the dissection involves these vessels. If there is a progression of the false lumen into your vessel and the false lumen finds an outflow, then you will have a perfused vessel. If the false lumen doesn't find a reentry, then you might have a pressurized false lumen and then a compression of the true lumen and a malperfusion. And again, if there is a complete disconnection of the ostium of the dissection, then you might have very variable forms of malperfusion or not of your vessel. So a recent paper has also shown that when in the same patient you see both mechanisms of malperfusion happening at the same time, and you treat them with TIVR, actually patients who have only been treated with TIVR without adjunct procedures on the target vessels, basically when the target vessel is involved by the dissection, you have poorer outcomes. So again, saying that we should probably be more aggressive in treating those patients. Diagnosis of visceral malperfusion is also challenging, and precision medicine there is lacking at the moment. When it comes to renal malperfusion, when you see a patient coming in A&E with a dissection and then you see a raised creatinine, then you should never forget that those patients that most of the time you will not know might have pre-existing chronic kidney disease, they might be hypotensive, hypovolemic, they might have had 2 or 3 CT scans. So it's very difficult to interpret the biology of renal failure in the acute setting of these patients. And therefore, radiological renal malperfusion should be interpreted very carefully. Mesenteric malperfusion is even more challenging to diagnose. It's insidious, serious, generally associated with poor outcomes. And the instrumental diagnosis in this patient, as we all know, is very difficult, as signs that you can see on the CT scan usually are too late to correct the underlying problems. And there are no reliable biomarkers with high sensitivity and specificity. And if you are thinking lactates, then be aware that lactates, as you can see also in this recommendation by the European Society of Emergency Surgery, are not reliable. And there is this recommendation saying that you should not use them to diagnose acute mesenteric ischemia. Diagnosis and the role of imaging. Of course, imaging plays a fundamental role in definition of the dissection, understanding the mechanism, and helping you making a precise diagnosis. CT scan is obviously our imaging of choice. It's widely available, high spatial resolution. It is a static in most of the protocols investigations. It can overestimate the false lumen. However, there are new protocols that are promising to give us new information with the CT scan. Anyway, first-line treatment for our patients. MRI is super fascinating, morphological and functional informations, non-ionizing radiations. However, availability in an urgent setting, slow acquisition times are a challenge. However, even here there are fast evolving protocols. Ultrasound modalities, of course, duplex scan of the arteries allow you direct study of your target vessels, particularly mesenteric and renal arteries in favorable anatomies, and can be very helpful, while IVUS and transesophageal ultrasound have mainly a role as an intraoperative tool. When it comes to renal malperfusion, again, I would like to highlight that we should always be very cautious in interpreting radiological malperfusion in the renal arteries. Ultrasound scan has been proven to be very useful when measuring end-diastolic velocity to predict malperfusion, and scintigraphy might play a role in the subacute and chronic settings, but not in the acute setting. This is a very interesting paper that has been published recently that outlines what we all know and think, but you can now see numbers on it. When you have symmetric perfusion of the kidneys, you still have 20% malperfusion of one of the two kidneys, and this was measured with intra-arterial measurements of the blood pressures. And if you see a radiological malperfusion, in 60% of the patients, you will have no malperfusion at all. Again, imaging of mesenteric malperfusion is very challenging, and usually we only see very late signs of mesenteric ischemia. There are some interesting studies about indirect predictors when looking at a CT scan about who is going to get or not malperfusion. This was a paper looking at SMAs involved by a malperfusion, so with a true and a false lumen, and then measuring the ratio between true and the false lumen within the SMA was a predictor of mesenteric malperfusion. However, we should also be aware that the way we are looking at imaging today is going to be completely different in 5 years. What we see with our naked eyes is not what we are going to use in few years' time. I don't know if you are familiar with the concept of radiomics, but radiomics, which entails a workflow of acquiring images, segmentation, generation of features, and then putting all this through machine learning, artificial intelligence, and then coming up with a computational model that you can run through any kind of data set, so you can reuse it endless time in any clinical context. We'll actually look, when you look at a CT scan, at things that we are not used to consider at all. Shape-based features. This first-order statistic features is just a linear description of the grayscale on the CT scan, or you can see texture-based features where this artificial intelligence will look at the relationship between voxel and pixel on a CT scan. And from that, you can get quantitative information that you can use for clinical decision-making, differential diagnosis, and predictor of treatment outcomes. You can see here so radiomics can be run through any kind of imaging you have. And for example, they've been used to diagnose and study dissections without contrast, but also radiomics and the data that you collect from radiomics can be integrated with clinical and biological informations in order to, for example, design nomograms that you will be able to use where all the informations will go together into an equation that will help you making a decision for your patients. Management of visceral malperfusion, I like to say always that the sentence must be proportionate to the gravity of the offense. If you think at the case that we've seen at the very beginning, would you do a debranching for a renal malperfusion? Maybe it is not appropriate. Endovascular treatment is the gold standard for complicated type B dissection with malperfusion. TIVR, covering the proximal enteroter plus or minus adjunct procedures. And as we have seen with Michael, there is an increased role of malperfusion first treatment in type A dissections, hinting also at the importance of a multidisciplinary approach to any kind of dissection. Endovascular treatment, just to summarize, in dynamic obstruction is mainly about correcting the dynamics between true and the false lumen, so TIVR plus or minus bare metal stents. Static obstructions, you need to go and intervene on the target vessel with stenting, sometimes with fenestration. And in a combination of both, you will have to use both TIVR and intervention directly on the target vessels. Recent evidence is showing that using of petticoat and stabilized technique actually provides better outcomes in patients with distal malperfusion, and so we should probably consider to use more this technique. Just a few words about a very interesting and somehow novel concept that I came across reading the literature. We are very well used to the idea that you have to aggressively control blood pressure in type B aortic dissections. However, when you have valve malperfusion, there is evidence that patients with a permissive hypertension perform better, as we all know is the case in spinal cord ischemia, but this might also become the case and the new standard of treatment when you have visceral malperfusion of the kidneys and SMAs. In few words, future perspectives, I think also stemming from the presentation from Professor Czerny, a unified practical definition of dissections we need to use across the globe. Advancing an imaging protocol will help us in decision making. Biomarkers are very fascinating, very promising. There is a lot of research about it, but nothing that has been translated in clinical research, and lactates are not actually a good biomarker. Radiomics and artificial intelligence and machine learning are going to change the way we are looking at imaging, and hopefully we will have one day or in a few years integrated nomograms that will combine radiological, clinical, biological features and help us in decision making. Thank you very much for your attention.
Thank you, Tommaso. Any question? There's a question in the back.
Thank you for interesting lecture. Just a question. Does decompression peritoneal catheter buy time till we fix the visceral malperfusion, or it has no role?
Sorry, does decompression of?
Decompression of the abdomen with the peritoneal catheter, does it buy time till we fix the definitive fixation of the malperfusion, or it has no role?
To be honest, I have no experience, and I'm not sure I can answer. I don't know if any one of my distinguished colleagues have an opinion about that. I'm not sure. I think it's an interesting concept. I apologize. I don't know.